I'm very honored to speak after this good surgeon, skull-based surgeon. I appreciate your effort to contribute in education in the field of skull-based surgery. I'm very proud also to represent my institution, the Neurosurgery Department, University Hospital of Modena and the Reggio Emilia, as you know, in the north of Italy. Now I'm going to talk about some rare case of Sellar lesion mimicking craniopharyngiomas that we treated them as if they were craniopharyngioma. The first case is a young boy, 12 years old boy, with a gradual onset of a headache, about 2 months of occipital headache, nausea, vomiting, neurological deterioration. During the hospitalization, the neurologic examination documented a symptom of intracranial hypertension and hemitemporal hemianopsia. So we decided to perform an emergent MRI that documented this solid lesion inside the sellar compartment, the suprasellar and the interventricular, with the occlusion of both foramen more and acute idocephalus. This lesion resembles a type 2 transinfundibular craniopharyngioma, like in the classification of CASAM for young people, for young colleague. I remember the classification of craniopharyngioma, very useful from endoscopic point of view. The type 1 plain-fundibular, more common, the type 2 transinfundibular craniopharyngioma, that's a unique lesion around the stalk. The retroinfundibular type 3, and also the type 4 totally intraventricular craniopharyngioma. These are the other image of MRI. This lesion is totally solid, without cyst, without calcification. It's quite unusual for a craniopharyngioma, but we treated this as a lesion, a benign lesion. In the FLAIR image, we can see some hyperintensity around the ventricular wall. There could be suspicion of infiltration of the ependyma. What are the possible approach for this lesion? Obviously, the terminal approach has the limit to see for the highest portion in the intraventricular. The same for the subfrontal translamina terminalis. For interhemispheric transcallosal transforaminal, we have a long approach and some difficulty to see the inferior part of the lesion. So we decided to operate this patient with the endoscopic transtuberculum approach. Some technical detail, the patient is positioned supine with the head slightly extended, different to normal pituitary position or clival surgery in which the head is more flexed. Normally, we prepare for a fascia lata withdrawal, okay, for the closure together with the septal flap. And another technical advice is the position of the endoscope during this craniopharyngioma surgery is to put the endoscope in the lower part of the nostril and the other instrument suction in the upper part. At the beginning, we use a 0-degree endoscope together with the ENT surgeon, this colleague, and then switch to 30-degree and 45-degree endoscope during the sellar phase and the intracranial phase. Now I show you a short video of the operation. I hope to see. Okay, these are the beautiful pictures taken from Neurosurgical Atlas. Important advice, technical advice is to open from medial optic carotid recess to medial optic carotid recess. This is the key point of this approach as a McCarthy hole in the pteral approach. If we remove both medial optic carotid races, we can see the junction between the optic nerve and the supracranial carotid artery. At the beginning, the lesion was not a craniopharyngiomas. Obviously, it was a very hard lesion, fleshy consistency. So we use an ultrasonic aspirator, and at the beginning, it was a very bloody lesion, probably due to vascularization from the inferior hypophyseal artery, from the cavernous carotid artery. We need to transfuse the patient 4 blood unit. Fortunately, after enlarging the diaphragm sella, we reached the intraventricular portion, and during this phase we were very lucky because between the capsule of the lesion and the ventricular wall there was a very good cleavage plane. Obviously, the histologic intraoperative examination concluded for a malignant tumor, for a sarcoma or a carcinoma. So we decided to perform a complete removal. This is the final part of the operation. We are inside the third ventricle now. Luckily, no infiltration of the epinemal wall. This is the last part. The tumor was totally solid. Okay. And now we can see the last portion, and the third ventricle is totally free of lesion. Blunt dissection. Okay. The chiasm is also free. And now the last part of the capsule of the tumor. Okay. Well, this is the CT scan after 3 hours of the operation. The patient, no clinical complications were reported after the procedure. Ophthalmologic examination documented almost complete resolution of the menopsia. Obviously, the patient underwent total hormonal replacement and was completely recovered at this stage. The MRI after the procedure is totally free of tumor. This is the last MRI after 7 years of follow-up. The diagnosis was very difficult, but at the end, the anatompathologist concluded that for a Ewing sarcoma, or also called peripheral pinette, this lesion constitutes a group of tumors originating from embryonal cells of neural crest with very aggressive behavior and a tendency for rapid metastasis. They are predominantly located in the pelvis, in the long bone, in the rib. The intracranial compartment is very rare, very rare. Only 27 cases were reported in literature. Only 1 case in the sphenoidal region, in which case they taken a biopsy, intracranial biopsy. Is pathognomonic for the diagnosis, the genetic consultation, because there is a typical translocation between the 11 and 22 chromosome. For the therapy is important determining the surgical removal and the early diagnosis. The surgical removal is generally the treatment of choice, and the adjuvant post-surgical therapies such chemotherapy and radiotherapy are required in most cases. Radiotherapy is normally limited to the treatment of residual disease. The patient is free of pathology after 7 years. Sorry, he underwent a cycle of adjuvant therapy, 6 cycles of vincristine, isofosfamide, doxorubicin, etoposide. He had a very good quality of life, no obesity, no pathological obesity. Briefly, the conclusion. This is, to our knowledge, this is the first case of a primary sellar suprasellar Ewing sarcoma confirmed by molecular genetic and treated by endoscopic endonasal approach. Our case highlights that the interdisciplinary therapeutic approach is mandatory to guarantee a favorable outcome. The other case is a 59-year-old man that with a clinical history of lineage, bitemporal menopsia, diabetes insipidus, and hypopituitarism. For this diabetes insipidus, we had the suspicion of metastasis. It's very frequent in the metastasis for the tropism of the stalk. But the patient had no further neuroplastic lesion, total body scan, CT scan. So we approached this lesion as a craniopharyngioma. We decided to perform a transtuberculum approach. At the opening, we observe a fleshy-like lesion, very adherent to the chiasm, and the intraoperative hematopathologic examination revealed adenocarcinoma metastasis. So we decided to perform only a subtotal removal, leaving a cuff of lesion around the chiasm. And then the histopathologic examination show a metastasis of the adenocarcinoma. Then we perform a PET total body that showed an accumulation, little accumulation in the area in correspondence of the cardiac, the stomach, which appears of dubious significance. Then we show the esophagoscopy, showed the presence of bloody ulcers, and then the conclusive diagnosis was of a cardiac adenocarcinoma. The conclusive remarks: the pituitary metastases are very rare, up to 3.7% of the pituitary tumors. The most frequent localization are the breast, lung, kidney, prostate tumor. Diabetes insipidus in a patient over 50 years old of age should always raise the suspicion of pituitary metastasis, regardless of malignancy. Cranial diabetes insipidus is the most common presenting complaint in pituitary metastasis. It is present in around 50% of pituitary metastasis cases. For the craniopharyngioma, the diabetes insipidus in the pre-surgical phase is present in quite 7%, 10% of cases. To the best of our knowledge, there are no reports of pituitary metastasis from gastric cardiac adenocarcinoma. In the present case, for the first time, diagnosis of occult gastric carcinoma can be reached following pituitary surgery. Okay, this is my conclusion. Thank you very much for the opportunity.
Thanks a lot, Professor Romano, for this excellent presentation. Is there any question from panelists? Okay, thank you for sharing with us this excellent cases.